Today, I'm thank Dr. Doval sir and giving opportunity to speak on this. What is the clinician needs about the thing regarding from the breast oncopathologist. Just I'm going to talk about the what are the things headings that they require important things as a important as a being oncologist. What we expect from oncopathologist, especially from the breast pathologist. There's a basic five major questions whenever a clinician is there, what it will come to in our mind. Is it a benign tumor as a malignant? Is it a borderline tumor is require going to become malignant or not? If it is there, it requires any need follow up or not? How frequent and follow up? It will come to in our mind actually. If it is malignancy is there, it is an aggressive tumor or a very slow going tumor. Even if it is there, how I'll treat it. This is the one thing. If I is a surgeon, surgical oncologist, if I do the surgery, did I remove everything tumor or not? It will come in a picture because I'll be dependent on the pathologist report whether I removed adequately margins or those things. These are things question will come to our mind. The answer is if malignancy is definitely will be worried about is a aggressive tumor or slow in tumor. How I'll do treatment. Mainly depend on this the priceless information mainly will come from the oncopathologist, the one who deal with breast oncology. That not like we are going to replace molecular test. Molecular test they are going to have addictive factor along the basic oncopathology related histopathology and the basic markers what we have. Like that is try to go make them tailoring the treatment based on the molecular test. Not only molecular test is not going to replace things. Basically, the basic oncopathologist report is more important for us. This is the thing we are having a classical prognostic and predictive factor. The older we used to have depend on the TNM staging, based on the T staging and nodal status, we treat the older method. Now we are trying to go so many factors are there, like prognostic and predictive factor based on the age, grading tumor, histological subtypes are there, and ERP or HER2, K67, and based on the margins and vascular invasion, we're going to decide based on the older T staging, nodal there the prognostic factor is there. The micrometastases are there important how pathologist the conventional method IHC method is try to see that one. Most of all the pathologists may not practice various institutions they'll try to practice nowadays. By IHC method try to prove that whether negative or not. These are things that are important. With early screening, all those things we are trying to see that very early T staging and even N0 diseases. This is the data from the Western data. But sentinel lymph node dissection and axillary lymph node dissection is a debatable because can we miss this nano or micrometastasis? Because if I don't remove, is there any chance of skip metastasis? These are the questions will come. There are a lot of things to answer for this. Clarification from the AJCC staging that when the multiple staging is the multiple tumor are there, we try to see the single largest tumor, what is the size we will try to see, but we do not include the satellite foci, anything is there. What are the multiple with the largest size of the tumor will be taken with the addition of the modified multiple factor. The bilateral is there, we'll try to do separate staging for each. But important thing is with the clarification of 7th and 8th edition, along with the gross and microscopic pathology, histopathology, we'll try to incorporate the imaging the finding along with the pathological stage whenever required necessary there. When the small tumor is there, we are taken from the biopsy. When the residual tumor is there, it is very small. It may give under staging of the result. Suppose 6 millimeter imaging is there by mass. We are taken most of by core biopsy. Remaining residual disease there, you have to see them, you have to correlate both histopathological and imaging. It's not like pathological T1A, it is a pathological T1B. Because based on the size, I'm not going to deal everything is what is the TNM staging here, but we supposed to correlate them, and this is most important for us actually. And if you don't find any residual tumor, don't try to categorize them as a pathological TA, a TX. Because by your already core biopsy, you take a small amount of the tumor, it will still comes to the category of pathological T1A. This is we have to see that when the multiple tumor is there, we have to see that we'll try to incorporate a clinical and imaging finding whenever things are there, pathological staging. But pathological TX is rarely used, but you try to correlate both pathological and clinical staging system. The important is the grading system. What you see, like most commonly grade 2 tumor in a clinical practice, grade 1, grade 3, almost 25%. Based on the grading, you can see that survival is going to come down. Low grade, there are a higher chance of tumor survival from the breast cancer compared to grade 3 tumor. They are very aggressive. They're trying to avoid either maybe triple negative or HER2 positive chances will be there. Whenever I read an oncopathology report, we try to see that what is the type of report is there, like any tumor microvascular invasion is there or not. You can see this, like if a vascular invasion is there, the chance of survival is less when it is absent. Because whenever things are like what are the high risk categories there, like T staging and N0 is there, ERP strongly positive. If a tumor microvascular is there, we try to see that these are things are there to decide additional chemotherapy required or not. Coming to the pathologist, like we'll try to tell them because basically we'll try to read that invasive ductal carcinoma. Very rarely we'll see that lobular carcinoma, but whenever pathologist as a being clinician, we try to have that what is a subcategory, because most of the pathologists may not try to give this, because I don't know where to talk to. We should have an interaction between the multidisciplinary system. We try to have an interact with them. Whenever findings are there, different clinical presentation, we try to ask them, we'll try to give a better answer from them. Because this category this, you can see that various categories there are a good prognosis. Tubular, mucinous type, cribriform type, you can see this right side. The secretory type, they're having the intermediate prognosis, like that adenocystic type. You can see that these are medullary type, all those things. That's why these different types are there. Then try to have a different type of prognosis together. But rarely this subtyping by morphology is only, it very rarely will come in a picture. Being clinician, we try to see that it may not hold good in all the cases. But even though it is comes in a clinical picture of 15 to 20%, at least we'll have an expectation from the breast pathologist if you're having a molecular subtype. Molecular subtype is not a only matter, because we'll try to rely on the ERP or HER2 and K67 and molecular signature, molecular genomic profiling. Coming to the special subtypes, because we know that we are more interested in triple negative, because we try to rely on the we don't have we'll try to rely on chemotherapy, radiation when required after the surgery. Because all triple negative, they are not a bad prognostic factor, but some other good types are there. Adenocystic type, secretory type, juvenile type, and we can see that this is the medullary type actually, and this is the metaplastic type, low grade and high grade. They're having a better prognosis on the left side of the tumor, and this one, and low metaplastic. The high grade metaplastic is having bad prognosis. These all triple negative are not same. If you're having these subtypes are there, you're supposed to have it is helpful for the clinician to decide for the treatment. This is you can see that histopathology with tubular form is there have a better chance of survival compared to non-tubular type. Medullary type also that. If they are compared to non-medullary type, they have a better breast cancer survival rate compared to non-medullary type. Other this is the same thing, tubular type and cribriform type. After surgery, you require mainly they most likely if they have endocrine positive will be there. They'll try to have endocrine therapies alone, that is sufficient without adding any chemotherapy. The other rare variety, you can see that lobular type, you can see that sometimes if the HER2 positive there, you have to cross check the really lobular type or any other variants are there, pleomorphic lobular type. Their chance of expression of HER2 positive will be there. They do bad compared to with alone endocrine therapy. They require additional therapy also required. That's why we supposed to rely on the oncopathologist. What is the clinical feature is not only the morphology, when the IHC is also important. It's we are most of the time we'll try to variant morphological subtypes are missing. I'll try to stress on if there wherever possibility is subtype of morphology there, try to helpful for the clinician to treat them. And apocrine also is a different variety. This is an important slide. You can see that breast histopathology and molecular alteration is there. You can see that left side is there is a lobular type. Lobular most likely ERP positive will be there, HER2 negative will be there. They try to treat with the endocrine therapy. The subvariant is there lobular pleomorphic type. There the chance of almost HER2 expression is there. They don't do well compared to other classical lobular type. Their chance of dissemination spread also will be there. You can have molecular a CDH1 mutation and PA3K mutations will be there. That's why we have to what are the variants are like if HER2 by simple classical IHC if is positive, try to cross-check the report is what oncopathology is given is right or wrong, or you have to clinically discuss with a multidisciplinary setting will be helpful. Other one is a micropapillary type. You can see that molecular alteration, three mutations can be there, mucinous type and a solid papillary type. These are things like various molecular mutations will be there in case of ERPR positive and HER2 negative tumors. If we come into the triple negative cases, you can see the metaplastic type, you can have mutations like PA3 mutations. There are some even now we are seeing the PD-L1 expression also, you can see more in even metaplastic type also. That is like there we try to see that even though we will come in a picture, we try to see this molecular alteration also. Adenocystic type and adenocarcinoma with lymphoid rich, like they'll try to more beneficial with the immunotherapy. BRCA positive chances will be more in this category. And like secretory junior type, there the NTRK mutation chances will be high. Coming to the prognostic and predictive factor. What are the prognostic factors? These are factors they are present in the day one in the diagnosis cancer diagnosis when from the day one. Their having factors are there. They try to see that the outcome is not good or bad. That ERPR like is positive is there. They're deciding the chance of better outcome with the therapy. Predictive factor is these are factors they try to decide that this factor by alteration of change of therapy try to decide the outcome. Predictive factor here like under HER2 positive by HER2 therapy, anti-endocrine and anti-estrogen therapy try to have a better outcome compared to without therapy. They are the predictive factor. And similarly, there is a well-established ER and HER2. There is like is validation done globally and clinically also it is validated. PR, even though it is both prognostic and predictive, mainly prognostic factor, because like a PR like negative like slightly more aggressive compared to PR positive. And K67 it is definitely helpful for a clinician. Like it is a like a subcategory we can divide into luminal A and B, and but is not validated all over. But in institution, each pathologist they can have variations of value. Like it is not standardized globally. But ERPR like it is positive more than 1%, but clinically will try more than 10%. They'll try to behave very well. They'll try to respond very well with the anti-estrogen therapy. And HER2 is like previously the definition was more than 30%. Now they're like a CAP guidelines they come down to like more than 10%. Complete membrane standing is there that they'll try to positive. Like they respond very well with the anti-HER2 therapy. Coming to the K67, why it is important? Because it is helpful to categorize them to luminal A and B and try to take a decision whether like they require chemotherapy in case of estrogen positive cases, borderline grade 2 tumor. Low grade tumor, I'll try to prefer mainly endocrine therapy. Grade 3 tumor, I'll try to prefer chemo followed by endocrine therapy. That's why this decision making in this kind of borderline tumor will be helpful when the basic these parameters are available. You can see this like K67, it is a very high grade. You can see that a lot of like staining is there in this one. And low grade, you can very rarely you'll see that positive rate in cases in low grade tumor. This is an intermediate grade. Actually, you can see 20% of people positive K67. This like is not validated because like each pathologist, like you can see that grading, clinical grading and K67 can vary, but like it can be like a variation based on the fixing technique, like and also like even pathologist like difference between the inter pathologist reporting also. It is not classically validated globally. Coming to the like the predictive factor like ERPR, if is more than 1% is there, we'll take as a hormone receptor positive. There are positive predictive with the response to anti-estrogen therapy, like 30 to 50% they'll do well. But if HER2 is there, they're having a highest chance of negative predictive value. If they're having HER2 positive, they like to bad when they're having a like HER2 positivity there. They'll do well with the anti-HER2 therapy. Coming to this is a subgroup. If the like ERPR positive is borderline, that is low, that is a 1 to 10% is there. Low estrogen receptor positivity, how they'll do? They behave like almost like ERPR negative there. This is the publication from our India. That is like one HC is also involved in this. Like you can see the graph, like ERPR, like ER is positive, they like to do well. The middle one is a pink one is like it's a low ER expression. They are almost like behavior is almost similar to ER negative tumors. That's why like a low estrogen receptor, it is even validated, even a molecular gene signaling this one essays also. It is like definitely we have to, when a upfront treatment is there, definitely whenever opportunity is there, like you have to see that one, especially young people, all those things, you try to go for chemotherapy, then try to maintain with the hormone therapy rather than just directly and only rely on endocrine therapy. That's why you have to have this like category, like this knowledge should be like available. If there are any variations of any of these reports are there, we have to definitely discuss with the pathologist, and the clinician should have interacted with the pathologist. This is the like important like from the clinician, what is the subtypes are there, all those things. That's whenever things are there, they have to have a clinical note from the pathology report, like we can discuss with like pathologist, anything is a doubt is there. The next one is like intrinsic classification of breast cancer. This is the taxonomy of the like breast cancer. You can categorize into like estrogen positivity, that is a luminal A right side, luminal B type, normal breast type, and a HER2 positive type, and basal like. This is the base like a gene signature pathway is going to decide them into various subtype of breast cancer, intrinsic like a different way. And you can see this is the graph. You can see that luminal A, they'll try to do very well compared to the like basal like. You can see that luminal B, you can see that luminal A and B, the prognosis vary, like that's why this gene signature pathway is going to decide. That's why like endocrine therapy is not sufficient in case of luminal B type. We try to definitely have addition of chemotherapy, try to have a beneficial. Coming to this is the graph showing the like various molecular biology of the breast cancer can influence the site of metastasis and chance of metastasis. You can see the brain, the chance of metastasis like environmental, mainly in case of HER2 positive basal like compared to luminal A and B. Coming to the like liver environment, you can see that more positive case in case of HER2 positive, almost 45%. Next is followed by triple negative breast or basal like tumor, less common in case of luminal A and B. Coming to the bone metastasis, also we'll try to see in the luminal B compared to other subtypes. Even peritoneal metastasis also more likely try to see in the lobular carcinoma compared to other subtypes. That's why like you have to, what are the molecular subtypes, try to have a different site of metastatic preference, all those things. This is the important thing what we do practice. This is the basic thing we expect from the breast pathologist. That is like we have to categorize them to luminal A. That is a luminal A is a ER pair positive, HER2 is negative, K67 is low, that is less than 14%. If any the gene signature pathway is available, it should be having a low score. Low score if is there, that is it try to label as a luminal A. Luminal B, that is ER is positive, HER2 is negative. Any one of them like a K67 high is more than 14%. ER can be low or it can be negative. Or like the recurrence score is showing the high score, it is taken as a label is as a luminal B. Coming to the like how we are going to treat luminal A, most of the time we'll try to treat with endocrine therapy, but some of the exceptions you can see that high risk category showing in the gene signature is there. You can see almost 25% of the, if we were having ER pair HER2 cases is 7, with gene signature pathway you are going to categorize as a high risk category. That's why if this signature pathway like is there available, you can categorize them into like you can that time require chemotherapy. And grade 3 tumor, and if there are 4 or more lymph nodes are there, or younger age is there, despite of even luminal A, require chemotherapy followed by hormone therapy. Luminal B, you try to have both like chemotherapy and endocrine therapy is important in this case. Coming to the like basal type, that is triple negative type. Almost like 80% of people, they variant, the overlap between the triple negative and basal like. That what is the difference I want to tell actually. See, triple negative, you are having a good prognostic factors. Almost 80% of people, like you can see that medullary subtypes are there, adenocystic, low grade squamous, and secretory carcinoma type. If these things are the triple negative, they are a good prognostic factor also, they come in a triple negative. But basal like they exclude these kind of factors. the question from the clinician is like this, from a pathologist, if they are report this one PR positive and ER negative is there, is it really that's reliable or not? We had last from breast pathologist, please cross check and if you like the biopsy is done from the core biopsy, if the surgery is done, we'll tell them to redo this ERPR on the whole specimen. Sometimes you are like a tumor adherence, you can miss that one. And lobular carcinoma, tubular carcinoma, they are having a good prognosis. If they're having HER2 positive, they definitely will cross check because like there are good prognosis. Low grade tumor, if HER2 positive there, is there anything pleomorphic variant is there? Low grade tumor, they're having a HER2 positive is there along with the ERPR positive. Definitely we have to cross check them. And grade 3 tumor, if they're having like A67 low grade and ERPR strongly positive, grade 3 is there, we'll tell them is this pathology reliable or not. We'll cross check them all the things. If you require that one, you can go for a second opinion. And if you have medullary carcinoma, there are lymphocytic infiltrates there, is very rare actually. We require a second opinion. This is the condition we'll try to cross check from the pathologist report. If they're like really this, we can't bluntly follow the pathology report. This is definitely clinically
okay.
Yes, sir. And this is like metastatic, like next is like metastatic, it is from the lymphoma and the other side should be there. Along with the basic prognostic and predictive factor, the important is like molecular, like if you are happy with this, the basic ERPR, HER2, all those things, the patient, they'll do well with oncologist treatment, other things, will be happy. If things are is not like holds good in all the cases, because there are various molecular changes will happen, it's going to decide based on the biology of the tumor. Because whatever you give the personalized treatment based on that one, many times like you try to go deviate and the patient may not get you, is going to get upset with the oncologist and even patient also and whole family. That's why the molecular signature is there. That's why we have that one is going to decide what is the variant biology of the tumor. There are tests are the mama pin and oncotype DX and the other thing Prosigna and endocritic. This is the slide is showing the all the various subtypes molecular signature gene pathway, like they try to tell them these are methods like they try to do DNA microarray, RT-PCR, all those things. With a fresh frozen plasma, we'll be using the mammogram most of the time. Not they get into low risk and high risk. Based on that one is enough. Sometimes in the intermediate in case of oncotype, Prosigna require the follow-up actually like endocrine therapy, sometimes require chemotherapy. The high risk definitely require chemotherapy. It is already guidelines are formulated. ASCO, ESMO and St. Gallen's, they are already following this one. But only thing is in India, whether we are following this or not, is it this tests are available or not, that is important. And any other emerging marker in the triple negative breast cancer, any other cancer, there do have that upcoming biomarker that is a stromal tissue lymphocytes. They are the predictive for the neoadjuvant treatment, especially in triple negative and HER2 positive. If they are having positive, they are trying to have a better response to the treatment. And prognostic, even though like the primary tumor and after the neoadjuvant therapy, residual tumor, if they are having positive, they'll have a better prognosis compared to those who don't have the TILs. And for the immunotherapy, if the positivity will be the TILs, they are having a better survival compared to those who don't have. The next slide, that the last one actually, that we're having other marker like molecular subtype BRCA positive and even HRD gene, and in especially triple negative tumor. If they're having this one, we're having a PARP inhibitor to treat that, and we're having a PDL1 expression that is a the SP142. It is a standardized already. FDA is approved for in triple negative breast cancer. We're having immunotherapy along with the chemotherapy combination in metastatic breast cancer. We'll try to have the other subtypes, maybe like a PIK3 mutation, ESR mutation, all those things. These things are there. We'll try to get the molecular subtypes, try to target them. The conclusion from my slide, like this, what are breast cancers heterogeneous? We'll try to classify them into variants, ER positive, ER negative, luminal A and B. Based on that one, we have molecular, various pathways are involved. Try to categorize them into different basket and try to treat differently. And even triple negative is there. Try to, some are there good variants are there, some are bad variants. Try to see the other molecular pathologist will have that more information. Try to treat clinically in a better way. Try to have immunotherapy is coming in the future and PARP inhibitor. Thank you. Any questions to take next?
Any questions for Dr. Satheesh? Satheesh, do you have any experience with one of our Indian tests that is done can assist best?
Can assist we are done, sir. We are done. Can assist I didn't cover because can assist we are done almost nearing around 45 to 50 cases we are done. We are but we are not correlated with oncotype DX both. But we are trying to see, especially they are not affordable for that oncotype we are done. Especially borderline tumor we are done, sir. But follow-up is hardly just 1.5 years. We don't have a follow-up to tell that really they are authenticated on this.
Okay.